to impact. My name is Tracy Harrison, your host, and today we're going to be talking about the gut. Many practitioners know that often disease begins in the gut, whether it's downstream diabetes or asthma or cognitive impairment, liver challenges, joint challenges. The gut is often the center of the functional imbalance that promotes systemic disease. A key reason for that can be the presence of dysbiosis, an imbalance in the commensal microbes, bacteria, yeast, fungal species that are present in a normal, healthy gut. Maybe the presence of pathogens, maybe the translocation of microbes from one compartment to the other. Many practitioners are aware of the gut centric role in systemic disease. They're even focused on the importance of assessing and resolving dysbiosis, especially in the gut. But here's the challenge. Too often, practitioners are focused on the gut and focused on resolving the dysbiosis by simply testing, finding something to kill, and then using antimicrobials to get rid of the culprit. But if you're a seasoned practitioner, you know that approach often doesn't work. You run a comprehensive stool test, you find a problem, you address it. A person feels better for what? 6 weeks, 2 months, but it returns. Maybe the exact same dysbiosis, maybe a different one. You test again or you adjust a protocol. They feel better for a time. Another recurrence, another treatment, another recurrence, another treatment. I call this the revolving door of dysbiosis. It's a persistent pattern that plagues a lot of practitioners, holding them back from the clinical outcomes that they seek in their practice, and also holding them back from the fulfillment that thorough, sustainable disease resolution would earn them and their patient alike. Whether we're talking about small intestinal bacterial overgrowth like SIBO, or maybe a yeast or candida overgrowth, dysbiosis can become this revolving door because obviously microbial overgrowths are a reflection of the environment that promotes them. And today we're going to be talking about 6 of the top reasons why gut dysbiosis recurs. And I want you to stick with me in particular to the last one because it's the one that is often overlooked by practitioners. So let's dive in. And first of all, I want to quickly clarify what I mean by dysbiosis. It's not simply the presence of bad bacteria. It reflects a disruption in the structure and the function and the signaling of the entire ecosystem of microbes in various cavities in the body, including the gut. And so I just want to highlight before I dive in that when I'm talking about dysbiosis, it might be loss of diversity and resilience in normal commensal microbes that we see in a healthy gut. We might see an overgrowth in the wrong location, like for SIBO or CFO. We might see an imbalance between commensal and opportunistic species, which often creates a pro inflammatory bias. We might see altered microbial metabolism where there's an excessive buildup of, say, histamine because of histamine producing species, or a buildup of endotoxins like lipopolysaccharide. Sometimes we simply see an overt pathogen that an individual has acquired, such as in particular a parasite that is wreaking havoc. So there are lots of different types of dysbiosis. Today's topic is about the 6 top reasons why dysbiosis keeps coming back. So, number 1 is about overfeeding the possibility of dysbiosis. Many of your patients and clients have some form of maldigestion, right? A digestive insufficiency. And there are a few primary types of this. And it's important to remember that what we don't well digest, meaning degrade for easy absorption down in primarily the small intestines, it's leaving excess dietary debris or food fodder, if you will, for our microbial friends. And this is where upstream from the microbial overgrowth, we need to look at how are we overtly encouraging an overgrowth by simply overfeeding them. This can present in particular in 5 specific forms. The first of them is hypochlorhydria or insufficient stomach acid. Many individuals who struggle with dysbiosis have this, and it's important to remember that good, strong stomach acid is a key component of digestion. In particular, it helps us to degrade proteins, helping us to unwind the yarn balls of polypeptide chains so that digestive enzymes can be more effective at cleaving those individual amino acids in shorter chains, again, for easier absorption. If we have overly alkaline gastric juices and some degree of hypochlorhydria, then we're more likely downstream to be overfeeding our microbial friends with an excess of amino acids, which they are perfectly capable of using for fuel. Often practitioners think only carbohydrates matter, right? Starches, fiber, this type of thing. But in fact, small intestinal bacterial overgrowth, for example, can really thrive on maldigested protein. And so we want to think about assessing sufficiency of stomach acid. Do individuals have early satiety after meals, perhaps burping or belching, or a full feeling in their upper GI tract, especially near the end of meals or very soon after them? They may also present with curious nutrient insufficiencies like serum B12 or iron or perhaps other minerals that might be a cue or a clue. If there's a history of gastritis or ulceration, often these can result from an overgrowth of H. pylori bacteria, which is kind of a double whammy because that is also a dysbiosis that can thrive when there's not enough stomach acid. But then part of how the H. pylori thrives is to further suppress our production of stomach acids to create a more hospitable environment for it to thrive in our stomach. So think about stomach acid sufficiency. For that matter, are your patients using proton pump inhibitors, which are creating hypochlorhydria on purpose in the name of acid reflux relief? That may be effective for that purpose, but it's a gross impairment in digestion in exchange. The second type of maldigestion is pancreatic insufficiency. This is insufficient secretion of digestive enzymes from the pancreas, which is where the lion's share of them come from. Many people in your practice have some type of diabetes. Might be full-blown type 2 diabetes. It might be early onset pre-diet or pre-diabetes, or even type 1 diabetes. All of these patient demographics have been shown in clinical study to be much more likely than norms to have some pancreatic insufficiency. And this makes sense that if the pancreas function has started to fail in producing optimal levels of insulin, in its endocrine function, that the pancreas has, of course, also likely started to fail in its exocrine function. Be sure to look for symptoms of maldigestion for individuals who have these various stages of metabolic disease or the autoimmune disease type 1 diabetes. Individuals with pancreatic insufficiency often wrestle quite a bit with downstream bloating or distension, and in particular, flatulence, gas, as a result, again, of too much maldigested food creating too much dietary debris for our microbes to feast on, especially further down in the small intestines and maybe even in the colon. A third type of maldigestion has to do with bile flow. Many individuals in your practice who have metabolic disease may also struggle with some level of fatty liver. People in your practice with hypothyroidism also have impaired flow of bile, which is a type of dysmotility, from the liver to the gallbladder, and may struggle with poor gallbladder emptying. All of these may simply lead to suboptimal levels of bile flowing into the small intestines. This category in particular surprises a lot of practitioners because bile is antimicrobial. And in fact, many of the most potent commensal or keystone species in our human gut microbiome have evolved to be resistant to the detergent like effects of bile. But you want to have good, thorough gallbladder emptying in a bolus of bile a few times a day in response to your meals in order to help keep microbial balance. In that way, things like bile and stomach acid and digestive enzymes are essentially part of passive immune function, helping to keep balance in the gut microbiome. So, any individual who has fatty liver, hepatic biliary congestion, maybe hypothyroidism. Maybe there's evidence of congestion in this system and it's post cholecystectomy. That's also questionable for just making sure that poor bile flow isn't part of what is creating this revolving door of dysbiosis. Another topic, so that's the first component of the terrain of our lives, other key foundational functions of the gut that can promote the revolving door of dysbiosis. The second of 6 categories is indeed impaired motility. Many people in our practices have GI dysmotility, and this is a primary regulator of microbial balance and also location. We want to have a good peristalsis and the migrating motor complex that's constantly sweeping our food fodder or chyme, right, through the small intestines, and also moving along microbes so that we don't allow them to overthrive, over proliferate on our dietary debris. This is important for preventing dysbiosis. But there are many things that can affect our normal motility. As I mentioned earlier, a key one is hypothyroidism. At SAFM, we like to say sluggish thyroid, sluggish anything in the body, because thyroid hormone, intracellular sufficiency, in particular T3 thyroid hormone, is controlling the metabolic function of all the cells throughout the body. And in particular, in our gut, we need good thyroid function to have optimal motility. There's quite a bit of subclinical hypothyroidism in your practice, especially with poor conversion of T4 to T3 thyroid hormone. This can be a major reason why motility continues to be sluggish, even after you have addressed other factors like good eating hygiene and relaxing to allow optimal digestion after a meal. Another key player in motility is indeed our serotonin levels. The vast majority of the body's serotonin is made in the gut, in the enteric nervous system. And serotonin is a key mediator of motility. If we have not enough serotonin synthesis in the gut, we tend to have more sluggish motility. We're much more likely to be prone to distension, bloating, and constipation or irregular bowel movements. On the other hand, if we have excessive levels of serotonin in the gut, we're more likely to struggle with fast transit time or potentially diarrhea. And this can also affect our microbial balance downstream. Motility that's too slow risks overfeeding our microbes, but motility that's too fast risks underfeeding our microbes. We're designed to have a nice, balanced GI tract that allows us to have at least one good, thorough evacuation of stool on a daily basis so that we are feeding our microbial friends just enough to help them thrive, but not too much to help them opportunistically overgrow. And so we want to think about, are there issues with thyroid function? Is there any evidence or driver maybe for suboptimal levels of serotonin? We also need good sufficiency of the mineral magnesium to have good motility. Magnesium plays a critical role in the body, in particular with contraction and relaxation of muscle. And this is key for allowing the pulsatile movement through the intestines to keep our dietary debris flowing smoothly. Again, not too fast and not too slow. So we want to think about GI motility. Always, always ask new patients and clients about their bowel movements and really dive into the detail. How often do they have bowel movements? What do they look like? How much of a complete evacuation does it feel like they are? What is their texture? What is the consistency? Can people see maldigested food in them? This type of patient inquiry up front can give you some critical clinical pearls. So that's the second of the 6 categories around what's promoting the revolving door of dysbiosis besides the microbial imbalance. And I hope it's starting to make sense to you. You can kill off an overgrowth, but if you're not addressing the upstream terrain parameters that permitted the overgrowth, then it's actually logical. Honestly, it's scientifically expected that the overgrowth will occur. Again, maybe the exact same one, or it might be actually a new type of dysbiosis. Our patients, and certainly us as practitioners, however, want our work in the gut to be sustainable so that your patients can have truly durable improvement in their gut function and in their systemic vitality. So number 3 is about the mouth. Now, this is a category that is often overlooked in clinical practice. If you think about it, though, the mouth is the top of the gut. It's not some separate part of anatomy. Often we don't think about the mouth. It's relegated to dental care and maybe oral hygiene, oral practice recommendations to that particular realm of medicine. But you might start thinking about the mouth as being the top of the gut, and what does or doesn't happen in the mouth can dramatically impair or support what needs to happen downstream. First of all, let's talk about chewing. It's a critical part of eating hygiene. In fact, we need to teach patients and clients to thoroughly chew their food when they have a meal, to sit down, breathe, relax. Ideally, take a moment, maybe to say a prayer or to take a few relaxing breaths, maybe meditate for a moment, focus on something pleasing and satisfactory to help calm our nervous system so we get more parasympathetic transmission. And as a result, maximize our digestive secretions and our GI motility. Our breathing, our behavior can play a large role in what our nervous system is able to do in optimally supporting our GI function. But once we start to eat, we definitely want to slow down and chew our food thoroughly, not just chew a few times so that we can barely gulp down our food or chase down a big glob of food with water. We want to chew it thoroughly, ideally until it's mostly liquid. The longer we chew our food, the sweeter it gets also. But this is a rare habit, especially here in the Western world, where mealtime generally is, besides dinner, is often considered to be just a necessity that people are speeding through. But we need to chew thoroughly in order to support all digestive function downstream. In addition to chewing, we want to pay attention to the microbiome in the mouth. It's incredibly rich. Might surprise you to learn that in a typical human mouth, there are as many as 600 or 700 microbial species that are also needing to thrive based on debris from our diet. And we are constantly swallowing not only food fodder for the microbes further downstream, but we're also swallowing the microbes that are present in the mouth. This means that downstream we can end up with problems with, say, candida overgrowth without necessarily making the connection that the candida is actually thriving in the mouth. We can be seeding a lot of dysbiosis downstream because of oral dysbiosis. This is where oral hygiene, good dental care, is critical for gut health. This involves not only regular toothbrushing, but also flossing. Yes, I'm taking a stand on flossing on a regular basis, because what you're doing, not only getting that pesky little food debris that's stuck between your teeth and so annoying, but you're breaking up the biofilm that can quickly build up in between our teeth and between the teeth and the gum, and getting nice down flossing, actually going into the kind of the crevice, if you will, of the teeth, and really cresting the gum so that we thoroughly break up that biofilm. This helps to prevent overgrowths in the oral cavity. However, what I highly encourage you not to do is to use antimicrobial mouthwash. This is a real challenge. Individuals who have bad breath, halitosis, often have it because they do have oral dysbiosis, and that is part of what is creating this undesirable aroma in the mouth. But when we use, for example, alcohol-based mouthwash, we often are killing off not only some pesky opportunistic species, we're also killing off some really beneficial ones. Research surprisingly shows that alcohol-based mouthwash, for example, wipes out a lot of commensal bacteria that produce nitric oxide in order to help us to maintain optimal blood pressure. Alcohol-based mouthwash is probably the worst culprit, but any type of antimicrobial mouthwash, especially potent ones, are potentially creating this issue. Instead, we want to think about, first of all, well hydrating so that we avoid dry mouth. We need good saliva flow in order to spread our immune function, antimicrobial peptides all throughout the mouth that can help to keep peace on the oral microbiome playground, if you will. We want to chew our food thoroughly, again, so we're not overfeeding microbes in the mouth or further downstream. We want to get good sleep in order to keep our immune function strong in the mouth, especially our innate immune system. And we want to avoid overconsumption of sugars that can predispose us for dental caries and potentially downstream for periodontal disease. And if we do have problems with dental caries, we certainly want to get those treated and supported as soon as possible. But just remember that oral ecology, if you will, is a key component of the overall gut terrain. What happens in the mouth is going to affect everything downstream, and the mouth is really the top of the gut. That's key consideration number 3. We're halfway done. So let's get into some of the juicier topics now. Number 4, often overlooked, medications. Medications can quietly sustain dysbiosis. It doesn't mean that the medication is not well indicated and may have been prescribed for a perfectly valid, appropriate reason. But all medications are foreign to the body. They're not nutrients, right? None of us has a deficiency of an NSAID or a deficiency of a steroid or deficiency of metformin or a proton pump inhibitor, right? They're all foreign substances. Ultimately, they're all toxins that the liver and the kidneys, for example, have to work very hard to degrade and excrete from our body in a timely fashion. Medications, we take them because we expect beneficial effects, but a number of them have mechanisms of action that can overtly promote dysbiosis. So let's talk about what some of these are. First of all, proton pump inhibitors and H2 receptor blockers, as I mentioned earlier, overtly create hypochlorhydria. PPIs even more so than H2 blockers, but they're creating maldigestion on purpose. They're not actually addressing the root cause of acid reflux at all, like so many other medications. They're just forcing the body to do something unnatural in the name of providing relief and also protecting a vulnerable tissue, in this case, the esophagus, from the effects of acid reflux. Many of you may know that functional medicine figured out a long time ago how to resolve acid reflux and is remarkably effective at it, which I should cover in another podcast. But these medications are creating maldigestion. And as I've already described, by promoting a very alkaline environment, are necessarily creating the perfect downstream setup for dysbiosis. And so, not surprising that those are often coincident. The goal would be to address the root causes of the acid reflux so that these medications are simply not needed. The second category I want to highlight are non-steroidal anti-inflammatory drugs, ibuprofen, aspirin, uh, naproxen. These are substances that overtly injure the mucosa, usually having a particularly marked effect in the small intestines, but it can have damaging effects on mucosa anywhere in the GI tract. This is because by virtue of being anti inflammatory, they are stopping the natural prostaglandin fueled process of healing the gut lining. And so this is a great reminder, by the way, that the immune system's job is not just about defense, but it's also about repair. And we need some amount of good pro-inflammatory oversight and repair in the gut on a regular basis so that our mucosa can be renewed and well supported for optimal digestion and for optimal digestion and absorption of nutrients, but also to keep good barrier function in the gut. And NSAIDs are highly used by many people in your practice, often as a just in case or because of aches and pains as we age, without realizing that it is wreaking havoc on their small intestinal mucosa and can be setting people up for increased inflammation in the gut. And also, when we degrade the mucosa uh, with enough intensity over time, we can impair the secretion of brush border enzymes in the small intestines, which is another source of digestive enzymes that we can end up maldigesting our food as a result of. Oral birth control pills, metformin, antibiotics, steroids, right? All of these are things that can wreak havoc on the gut. Metformin is a widely used medication, but in particular, it can contribute to loose stools, rapid transit time in many of your patients. That's actually quite common. Sometimes your patients innately have maybe constipation, but they take a metformin and it speeds things up to where they have more of a normal bowel movement. So they may not be aware of it. But this is a classic challenge with metformin. And a common challenge with metformin is that via its mechanism of action, it impairs absorption of vitamin B12 in the ileum, in the small intestines. So, a small clinical aside for all of you practitioners, be sure to check serum B12 in all of your patients using metformin and make sure that the levels are truly optimal, ideally above 650 picograms per milliliter. Nanograms per milliliter. This is really important for making sure we have optimal vitamin B12 absorption in the body. Metformin may be in the way of that. Antibiotics are an obvious category, right? If we are overtly using toxic compounds to try and kill off a pathogen, kill off a alarming infection, of course, we're more vulnerable to also killing off a lot of commensals then perhaps some well adapted, resilient, opportunistic species or pathogens might more readily thrive. On the other side of the antibiotics, there's less competition for food, for space, for resources in the gut. Antibiotic use can unfortunately overtly increase the risk of other downstream dysbiosis. And you've probably seen this happen over and over again in your practice. So that's the fourth of six categories. Let's talk about number five. This is an obvious one, but one I think that bears a little discussion. We have to focus on diet. Our microbial friends in our gut thrive only to the extent that we feed them appropriately, that we're not sending down too many antimicrobial compounds, we're not sending down too many toxins, highly refined chemical laden foods. But on the other hand, via good focused diet, but also optimal digestion and eating hygiene, we want to be feeding our microbiome all sorts of phytonutrients from colorful plant foods that we consume, all sorts of fat soluble vitamins that we acquire, especially from healthy animal foods. We want to ingest a rich diversity of complex starches and fiber that can help to feed our microbial friends. These types of nutrients and also prebiotic substrates are crucial for feeding our microbiome. In the same way that our children's behavior is radically different, whether they're living off of kid food, which in the US tends to be, unfortunately, a lot of calorie rich, chemical rich, marketing driven, nutrient poor junk food versus whole, rich, diverse foods that our human microbiomes have naturally evolved over time to thrive with. At the same time, people can pursue very restrictive diets that may not be well fueling the microbiome. In particular, individuals who are following very low carb or ketogenic diets, or maybe carnivore diets, may not be ingesting enough phytonutrients and enough fiber to help their microbiome to be fueled. Even with a lower carbohydrate diet, we can still be consuming dark leafy greens and very low glycemic fruits, for example, like berries, that can help our microbiome to thrive, even in the face of a more restrictive type of diet. So we want to be remembering that our microbiome thrives from a nutrient viewpoint, really only to the extent that we make a choice to feed ourselves those foods. And that our dietary choices can be a major driver for dysbiosis recurrence. We have to feed the microbiome if we expect it to thrive. In particular, some of our keystone species in the gut are using prebiotics from our diet to make different types of short chain fatty acids as a byproduct. And then other species are consuming the short chain fatty acids to make their own beneficial byproducts. In that way, we are part of the food chain for our gut, where we feed the top of the chain microbes and they feed others and they feed others and so on. Diet matters for many more reasons than you might have imagined. But the last category that I want to talk about is really the one that is most often overlooked. This is the sixth of the six major drivers of the revolving door of dysbiosis. And I want to talk about our nervous system. We don't often think about the nervous system highly affecting the gut, much less the nervous system affecting dysbiosis. But of course, this is yet another example of powerful interconnectedness across physiological systems in the human body. Many people in our practices struggle with too much stress. It's ubiquitous to the point where it feels almost boring to talk about it. But we can't lose sight of just how much this changes dramatically our physiology and biochemistry. The sympathetic nervous system, when it's active and promoting fighting, flighting, hiding, and fawning in the name of survival, naturally deprioritizes certain systems, certain processes. If the body's trying to fight and flight and survive and just make it till tomorrow, the body in its wisdom doesn't really care very much about digestion. The body doesn't really care too much about GI motility. And especially chronic stress dysregulates the immune system. We have a suppression of innate immune function, which can be just that opening of the door that allows an opportunistic overgrowth to thrive. So the nervous system is not just about moods and cognitive processing, right? It's also about stimulating via the vagus nerve all sorts of critical GI functions. Like I said, digestive secretions and motility in particular. And so this is where eating hygiene that I described earlier is trying to make space in perhaps an otherwise stress-fueled day to relax, to take a few breaths, to calm the body, to focus on something positive, to create a parasympathetic nervous system moment on purpose in the name of optimally supporting digestion and motility, in the name of avoiding dysbiosis. But of course, we have a powerful opportunity to work with our patients and clients overall about acknowledging and working on improving their typical nervous system state. The reality is that so much disease begins in the gut, but honestly, so much systemic disease begins in nervous system imbalance as well. And in cultures like the US, where we tend to celebrate stress, we kind of heroify stress, and we celebrate it as being a person who's accomplished and successful and driven, and doesn't have the weakness of needing rest, or doesn't have the weakness of needing a longer night of sleep, or powering through and deprioritizing self-care or relaxation or even vacation. These are toxic cultural norms. They do not at all promote health and vitality and longevity, despite their popularity. We want to teach patients about the importance of frequent extended parasympathetic nervous system states that allow good vagal transmission for supporting the health of everything in the gut in the name of minimizing the risk of dysbiosis and creating the revolving door that so often is at play. And I highlighted this one as number 6 because often it is the thing where even very savvy practitioners, they've tried everything like, oh, okay, this is the third set of dysbiosis. I've focused on digestion. I've improved the motility. The eating hygiene is sound, right? We've addressed all the things. Why is this coming back? I encourage you to think about the underlying nervous system state. And does your body believe in its wisdom? Does your nervous system believe that what it needs to do is prioritize survival? Or does your nervous system feel free to prioritize the opportunity to thrive? This is an important choice, and we must learn and accept responsibility for the fact that our nervous system is taking lots of cues and clues from our behavior. Choices such as slowing down and practicing mindful breathing, especially nasal, long exhalation breathing that can overtly trigger, even after just a couple of minutes of a mindful breathing episode, can trigger higher heart rate variability and also improved parasympathetic transmission, right? Better vagal tone. This helps to create downstream from the nervous system a much more balanced terrain that minimizes the risk of dysbiosis and helps to ensure that your patients and clients are more likely to thrive. So I thank you so much for joining me today. The reality is that recurring dysbiosis is not random. And it's not just microbial. There may be the occasional pathogen here and there. The vast majority of dysbiosis results from, logically, scientifically, from a terrain that is promoting that dysbiosis. It reflects a system that continues to actually select for that dysbiosis. So I encourage you to shift from asking, what dysbiosis do I need to kill off? What do I need to eliminate, right? What's the antimicrobial protocol? Shift instead to start asking, what in the overall system environment is allowing this dysbiosis? And when we do that step by step, we have the ability to slowly stop, slowly resolve the revolving door of dysbiosis so that ultimately it can come to a halt and your patients can thrive. Thank you so much for joining me. Have a great day.